Good afternoon. My name is Heather Iliff. I'm President and CEO of Maryland Nonprofits, and I'm delighted to be joined here by Dr. Clifford Mitchell of the Maryland Department of Health. Dr. Mitchell is going to give us a presentation, COVID-19 Guidance for Communities, Businesses, and Schools. And we're so pleased that he's also willing to answer questions from the community. And we've already gotten some in advance that people have emailed in. I know that people are really hungry for the information that you have to share today. And let me just provide a couple of logistical notes. So we do have a Q&A section at the bottom, and you can put your questions in the Q&A section. And there may be, I believe we enabled, and I can't see it right now, this will be the first time we're using it, the upvote function. So if there's a particular question in the Q&A that you're particularly interested in and you want to thumbs up that question, please go ahead and try that feature. Hopefully that is enabled today. And Dr. Mitchell has a PowerPoint presentation to share, and then we're going to go to your questions. And just a couple of other notes before we get started. Make sure to visit marylandnonprofits.org, our COVID-19 resource page, where we have a lot of up-to-date information for nonprofits, and including grants and other things that you need to get through this difficult time. And I want to thank everyone on the call who is a member of Maryland Nonprofits. We do have a weekly member call coming up on Wednesday at 3:30 p.m. And you can sign up for that through the member portal or on our website under events. 3:30 on Wednesday is going to be the time going forward for our weekly member call. And for those of you who are not yet members, most of our COVID-19 related programming is free. And we also have a free newsletter on our website where you can sign up there. And we hope that you'll also consider becoming a member. So without further ado, I'd like to turn it over to Dr. Clifford Mitchell, and he's going to share with us the latest on the COVID-19 in Maryland. Go ahead.
Thanks very much, Heather. All right, that was I probably. I was very relieved that you have only an upvote. I was worried that there was a downvote corresponding to the speaker, and so that was somewhat reassuring that was not the case, or that you just didn't let me know so that I could go on ignorantly and in bliss.
Right.
So thanks so much, everybody, for hopping on today. And so, as Heather said, my name is Clifford Mitchell. I'm the director of the Environmental Health Bureau here at the Maryland Department of Health. Just to sort of give you a little bit of background as to how I came to be here, or more importantly, how you came to be listening to me. The Department of Health has obviously been very much engaged in responding to COVID-19 since before the very beginning of the governor's executive orders, and the first cases appeared here in early March. So through the month of February, the department was getting ready for the possibility of a significant event here. None of us quite knew what the scope and magnitude would be, but we've been very busy for four plus months in preparing for the—
Dr. Mitchell, I apologize. Can I interrupt you for a second?
Sure.
Someone has said in the Q&A box that the sound is not coming out well. If anyone else is having sound issues, can you please let us know? I'm hearing Dr. Mitchell just fine. So if anybody else is having sound issues, let us know. And also, we are recording this webinar, and the recording will be available on the COVID-19 page of our website. So people are chiming in that the sound is fine for them. So sorry to interrupt. Go ahead, Dr. Mitchell.
No, it's quite all right. So I'm using a microphone, which generally speaking works well, but I know that occasionally with Zoom you will have problems. So I apologize for that. And as Heather said, the slides will be available, and I'm available always if you have questions following this presentation. So as I indicated, we've been working hard for about 4.5 months to get ready for this. And since the first case appeared in Maryland in early March, the health department has been working cooperatively with state agencies, our federal partners, local health departments, and local governments the business community, the non-governmental organization community, pretty much everybody in the state, to respond to COVID-19. My role in the department's response ostensibly has to do with higher education, business, and the environment. My background is in occupational and environmental medicine and internal medicine, but I've been doing a lot of work with all sectors of the department's response. And we have series of teams that are doing everything from testing to working with private primary care providers. There are, as you know, very many things happening. So what I wanted to do was give you an overview of where we are in the process, share with you some thoughts about where we are in the pandemic, talk with you a little bit about some of the issues that would be of, I think, particularly of concern to you as not only nonprofits, but as organizations. And a lot of this is predicated on the idea that you, like other organizational entities, are trying to figure out how to work in the context of COVID-19. And as you'll see, I think one of the things that we're trying to do through this whole process is help you build skills and competencies and practices that will allow your organizations to continue operating with the expectation that COVID-19 is not going away anytime soon. So let me just sort of walk you through where we are and where I think we are, and talk with you about how to think about COVID-19, and at least how I think about it, and then share that with you in a way that will then lead to some organizational, I think, discussions with you all. So, as you may all know or not, coronaviruses are a family of viruses that primarily cause disease in animals. However, human coronaviruses, such as the coronavirus that causes colds, are quite ubiquitous. And occasionally you will have animal viruses that jump to humans, and even more rare than that is the coronavirus that jumps from animals to humans and then is able to be transmitted continuously from human to human without having to have an animal intermediate. So first example of that in modern times was the severe acute respiratory syndrome, SARS, which in the 1990s caused severe infections in Asia, in Hong Kong, other parts of Asia, and then also in North America. SARS was interesting because it was so lethal to its hosts when they became infected that it did not perpetuate itself. So it sort of burned itself out. And one of the attributes of viruses that makes them successful or not is the ability to reproduce before they kill their host, or even better, to keep their host alive, but use their host to perpetuate the virus. So SARS was an example of a somewhat inefficient but highly lethal virus, which was so lethal that it didn't become a pandemic. Second coronavirus that you've probably heard about is MERS, or the Middle East Respiratory Syndrome. This is a coronavirus that's actually found in camels and in camel milk, and also is capable of causing, like SARS, pulmonary disease. And we occasionally still will be asked to look and test for possible MERS in humans who have pneumonia. And there are cases of MERS that do occur in the Middle East. But so far, MERS has not, fortunately, become something that is transmitted human to human efficiently. So finally, there is the novel coronavirus SARS-CoV-2, severe acute respiratory syndrome coronavirus 2, and that is what is now more or less affectionately nicknamed COVID-19. So a little bit about how this it spreads. So it spreads person to person, primarily through respiratory droplets from the cough and sneeze. And it also transmits as what are called fomites, and those are small virus-laden droplets or particles that are on surfaces that can be picked up and then typically either ingested or inhaled. If you touch a surface with viral particles and then touch your face, you can transmit the virus through your mucous membranes, the eyes, the nose, the mouth, and then you can become infected. So the incubation period is a minimum of 2 days and a maximum, generally speaking, of 2 weeks. Most people have symptoms. The median or the mean of incubation is 5 days. That is to say, 5 days from the time that you're infected to the time your symptoms start. And almost all people have their onset of symptoms within a week. So we use 2 weeks as the outside period, but most people actually develop symptoms within a week. And the symptoms, originally cough, shortness of breath, fever, have been advanced by newer understanding and clinical histories to include some less frequent symptoms, which by and large are sort of, you would put them in the category of flu-like. Muscle pain, sore throat, interestingly, the new loss of taste or smell, which people have generally heard about, or gastrointestinal symptoms like nausea and vomiting. So who's at risk for more serious disease, and how does COVID-19 actually affect people? So before I talk about the risk factors, so COVID-19, when you ingest it, the particles typically will work their way down the gastrointestinal tract or into the lung. And there they cause a couple of different things to happen. One is that the viruses start replicating and people start shedding the virus. The whole point of a virus is to replicate itself. In the process of that, they trigger an immunologic reaction. And this is where the serious complications of SARS occur, because oftentimes people who have this immunologic reaction may have what's called a cytokine storm. Or basically what happens is their body is working, their immune system is working so hard to overcome the infection that the inflammatory response, the immune reaction itself, becomes a process that damages or further damages the lungs, leading to what's known as acute respiratory distress syndrome, or ARDS. The problem with COVID-19 is primarily a problem in the lungs of not being able to transfer oxygen from the lung to the blood, and that loss of oxygen and that deficit of oxygen is what is the most serious health problem for most people. There are other complications. People have experienced kidney failure. People may go on to have other problems, and you've heard more recently about the children who in small numbers appear to have a sort of a post-inflammatory reaction. But that's not what kills most people. What kills most people is the lung problem itself, the oxygen problem. So risk factors for serious disease include age 65 and older, people who live in congregate facilities, especially nursing homes or long-term care facilities. And then other high-risk conditions include pre-existing lung disease or heart conditions, people who are immunocompromised, or people with a number of other health problems, including severe obesity, diabetes, or kidney or liver failure. I should add that at this point, although you can find COVID in people who are pregnant, it has not been shown to transmit vertically to a newborn. So far, it looks like the fetus is relatively protected while in utero from COVID-19. However, once the infant is born, a newborn is at risk either from close contact with the mother or breastfeeding, not because of breast milk, but because of the theoretical possibility of just being close to the mother's breathing. And so there are specific recommendations to protect newborns. There is no specific medical treatment. The Infectious Disease Society of America has recently, actually just over the weekend or within the last couple of weeks, released recommendations for treatment, but all of these are experimental and should be done in the context of clinical trials. There's no proven medication at this point. And there's also no vaccine, as you all know. So this, you will have observed, is the front page of the Maryland coronavirus dashboard. This was taken from yesterday's dashboard, and you can see that we've got in the state, we have identified 32,587 cases. We've been averaging somewhere around 1,000 cases newly tested and identified each day. We have had 1,538 deaths. And we may or may not be starting to see the number of deaths decrease slightly, but it's too early to say that for sure. And we've got a lot of negative test results. And we have a lot of people in the hospital, 1,640. Now, a couple of words about this. The first is, as you recall, the first cases were reported in early March, the weekend of March 5th. And since then, obviously, we have significantly ramped up testing. We have significantly increased resources in the state. We have been building additional beds for hospitals in temporary facilities to house the anticipated surge. And as you know, the governor has issued executive orders and worked very closely, and we've worked very closely with the governor's office and our partner agencies. And the whole goal of that has been to do what's called flattening the curve, as you can see in this graphic, where the number of hospital admissions, which is relatively independent of our testing capacity, has been. So for the last several days, our number of admissions to the hospitals has been relatively flat. We continue to see many outbreaks in nursing homes and in other congregate housing facilities. Those are continuing. And this is from a statistical modeling program at the University of Pennsylvania. It's online, it's a publicly available model. And I just show this to you because I just wanted to show you. So if Maryland's population is 6 million or so, then as you can see, here's the 6 million people of Maryland. And here, as you can see, here's early March. And as you can see, we've been gradually increasing the number of cases that we've identified by testing. But here's the problem. Most infections with coronavirus are asymptomatic. That is to say, they have no symptoms or very mild symptoms. So we have no idea how many people have been infected and how many people are still susceptible. So this curve at the top here, here's the total population of Maryland of 6 million or so. And we know that an increasing number of those people have been infected. And we think, but we're not sure, that being infected means you're less likely or not likely to get infected again, although that's definitely not proven. So the number of people who are susceptible to infection, that is to say, who could potentially become infected, is starting to fall more significantly, because here's where we are right now, and you can see we've still only infected a very small number of people, we think, of the total population, but we really don't know. And there's a lot of controversy right now about whether or not it's possible that we've actually infected more people here at this point, which would mean that the disease is less deadly than we think, because a larger number of people have been infected relative to the number of people who have died. But we really don't know, because we're not doing any systematic testing across the state to know how many people who are asymptomatic actually are either carrying the virus or have been exposed and have developed antibodies. So, what's our goal? Slow the spread, protect vulnerable people, maintain vital services, adjust to local conditions to be flexible, and as much as possible to maintain what might be considered normalcy in abnormal times. So I want to spend a little time with you just talking about how we think about different exposure categories here. At this point, with widespread community transmission, everybody in the US should be considered to be at risk, which means everybody in the US should be alert for symptoms, looking for fever, cough, or shortness of breath, taking your temperature if symptoms develop, practicing social distancing, and here in Maryland, wearing facial coverings if you're in public. Other than that, there are people who are exposed or who have been confirmed as having had COVID-19, either because they've been tested or because they have the symptoms of coronavirus. And those people should also be considered to be in a separate category. Those people should generally stay home until 14 days after the last exposure. They should self-monitor for symptoms. If they develop symptoms, then we'll talk about what should happen with them. So, so how do you as an organization operate in the context of COVID-19? So there is a lot of guidance out there, but your goal is to protect your staff, protect yourself, and protect the people whom you are serving. And how do you do that? Well, you do that the same way that we advise businesses and other profit-making institutions, because the recommendations for everybody is essentially the same. Sick employees should not be working, period, end. There's no, if an employee is sick, they should be home. If a volunteer is sick, they should be home. We don't want people who are sick to be in the workplace or elsewhere, because they are clearly shedding virus, and we are clearly therefore exposing other people. So we really encourage people, we want anybody who's sick to be home. Social distance policies. The governor has been very clear about this. We've tried to be very clear about this. Maintain a 6-foot separation from other people. When that's not possible, use a face mask, a cloth face mask. Employers should have flexible policies for telework and leave, and I'm sure you all have those. Cough and sneeze hygiene, hand hygiene, which is to say frequent hand washing, at least 20 seconds, or hand sanitizing if hand washing is not available. Routine and frequent environmental cleaning, especially high-touch surfaces. This is that thing about the fact that you can have virus particles on inanimate surfaces, and they can last for quite some time, hours to in fact days in some cases. So the more you clean, the fewer the viral particles. Education and training of your staff, as well as your constituents, your clients, open communications, and minimizing travel. All of those are important parts of prevention at work. Facial coverings. At this point, everybody who's out in public should be wearing a face covering. I have to tell you, I was out this weekend at Loch Raven Reservoir And I'm sorry to say that we were we were a we were in the minority of people who were out enjoying themselves in the fresh air. And it's great to be out in the fresh air. And if there's nobody else around, that's fine. But if there are other people around at all, there are at least two important reasons for wearing facial coverings. The first is, obviously, it protects other people from you if you're wearing a facial covering, because when you sneeze or cough, those larger respiratory droplets won't be sprayed all over. They'll be caught in the mesh of the facial covering. The second thing is, and I think that this is important, although we don't talk about it as much, if you're wearing a facial covering, it's a reminder to you, as you see somebody in a facial covering coming towards you, why is this person wearing a facial covering? Well, it's because there is a pandemic going on. And we all need reminders of that every day, because, our tendency is to try to be normal, and it's not a normal time. So, my general recommendation is always, 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 always facial coverings. And then I finally want to note, for other personal protective equipment, a lot of these are in very short supply. They're not going to be readily available in all cases. So we can talk about what are the important things to do in that regard. Okay, so let's talk a little bit about you as an employer or you as an organizational leader. What are your policies for your employees or your volunteers? So first is sick employees, stay home, stay home, stay home. You want them to feel that they are protected. You want your other staff to feel protected. Employees who are sick should not return to work unless they are, and herewith, I'll give you some additional guidance on these, fever-free and symptom-free for at least 72 hours. And I'm going to go through these in more detail. You should not be requiring a note from a healthcare provider for people who are out sick. There's no point to that at this point. The healthcare providers are overwhelmed. They do not need to be writing out sick notes for people. And we want companies to encourage their contractors to have the same guidance. So this is updated guidance as of basically this weekend for returning to work if you have been socially isolated because of suspected COVID-19.
Dr. Mitchell, can I pop in here with a question?
Sure.
So we are recording the webinar, and we're going to make the recording available on our website. People are also asking about the slides, and now that I see you've got some detailed guidance here, they might want to copy and paste. Can you send us the slides afterwards?
I would be happy to do so.
Okay, so yes, the answer is yes on the slides, folks. Thanks.
Yep.
All right, go ahead.
So the first thing is, so for people who have been, who have suspected COVID-19, that is to say, they've got symptoms that are consistent, or they've been tested and found to be positive, and they're symptomatic, they can return to work when at least 3 days have passed fever-free without the use of a fever-reducing medication, and they have improvement in their respiratory symptoms, and at least 10 days have passed since their symptoms first appeared. Those three conditions have to be met. So fever-free, improved symptoms, 10 days since symptoms first appeared. That's if you've had symptoms. Now, as we do more testing across the state, we are finding a larger number of people, and we're going to continue to find more people who are asymptomatic. That is to say, they don't have symptoms. So how and when can those people return to work? So CDC has been considering this. This is not an easy question, because we don't know how many of those people are going to go on to develop symptoms. And we don't know whether or not, if they are shedding virus, that is to say, if they have virus that's detectable, whether they are infectious to other people. We think, well, I'll talk about this in a minute. So if you have a staff member who is COVID-19 positive by test, but has not had any symptoms, then they should wait at least 10 days since the date of their first test. And if they have not developed symptoms in that time, they should be able to return to work. If they develop symptoms during that period, then that puts them into category 1. Then you're using the category 1 guidance. Finally, it should be noted that even if you are asymptomatic, that does not mean that you are not infectious if you have virus. So you really want to be careful with people who come back to work who have been asymptomatic. They should just be very, very conscious of the fact that they want to try to avoid exposing their coworkers. All right. Number 3, if they've got no symptoms and they haven't been tested positive, but they are taking care of somebody who has got COVID-19 in their family, or they have an intimate partner who is COVID positive, or they're a healthcare worker in if they're providing care in a non-healthcare setting without using precautions to an individual who has COVID-19 or is suspected of having COVID-19, those employees should be sent home for a period of 14 days. That's to protect them for the period of time that they might develop symptoms. If they don't develop symptoms, they can return to work as long as they meet these conditions. No fever. If they develop symptoms, their symptoms have improved and at least 10 days have passed since the symptoms first appeared. So that's for people who are not themselves positive, but they are a contact of people who are lab confirmed or symptom confirmed COVID positive. Now, what happens with employees who are within 6 feet for longer than 15 minutes with someone who has suspected or confirmed COVID-19? That is the same kind of situation as we just talked about above. They would be considered to be a close contact. They should be home for a period of 14 days. If they develop symptoms, then they should be flipped back to category 1. Or if they're tested during the time that they're asymptomatic and they test positive, then they would fall into the category of 2, which is to say no symptoms but tested positive. All right. And I realize there are a lot of these, but these are the situations that people are finding, and that you may very well confront any one of a number of these. Now, what happens if you've been in the same indoor environment as a person with suspected or confirmed COVID-19 for longer than 15 minutes, but you don't meet the definition of a close contact? That is to say, you were in a waiting room or a room of some other kind with somebody who turned out to have COVID-19. It's time and proximity determines the likelihood of infection. So if you are passing somebody in a grocery aisle who happens to be COVID-19 positive, and that possibility certainly exists, if it's just a fleeting contact, your chances of developing COVID-19 are very small. If it's and if it's farther away than 6 feet, for most intents and purposes, your chances of developing COVID-19 are very small. And under those circumstances, you don't have any work restrictions, and you should just self-monitor for symptoms. All right, now what about, finally, if you've had close contact, but you are a critical infrastructure employee? This, in many cases, may not apply to you, but there are certainly some folks who work in what are considered by the federal government to be critical infrastructure. And those folks are, in fact, allowed if necessary. It's not preferred, but it is allowed. They are allowed as long as they wear facial covering and meet other conditions that are mentioned here. They are allowed to return to work with the understanding that if they become symptomatic, they have to leave work immediately. Now, a word about cleaning. You should do it frequently, and especially high-touch surfaces. doorknobs, keyboards, touch screens. All of these are high touch surfaces that should be cleaned frequently, bathrooms obviously as well. And the EPA has a list of disinfectants that are registered for use against COVID-19. Those are available for download, and you should be using those if you have COVID-19. In addition, I've provided some additional resources on coronavirus generally, and then some more guidance for businesses and employers and small businesses and employees to be able to see some of the guidance that's there. And then I've also provided some specific information around other kinds of questions that have come up. And these include infection prevention in the home setting, faith-based organizations, mass gatherings and large community events, and then non-pharmaceutical interventions. Those are unfortunately the only kind we have at this point, things that help to slow the spread that are already in effect in Maryland, thanks to the work that the governor's doing, the legislature, and you all. So finally, let me just say a word about congregate housing scenarios. We are seeing an increasing number of outbreaks related to congregate housing. There are many reasons why this is happening, but part of it is staff go in and out. And if staff go in and out, then the disease, unfortunately, can go out in and out with them. So it's really important to use screening questionnaires. It's usually it's very important to try to maintain security in the facility by taking temperature or doing screening questionnaires for symptoms. Those are all things that will help. None is perfect, but they'll all help. And so if you are in fact running a congregate housing facility, then you really want to make sure that you've got a plan, you've got communications, you've got signage, you've established clear visitation policies. All of those things will help. So let me stop at this point and turn back to you, Heather, and see if we have any questions.
Thank you so much, Dr. Mitchell. We did have somebody say, thanks, these are so great. Our team will be very grateful to have this information, so much appreciated. So far you're doing great. And I just also want to say, you know, thanks to the health department, thanks to you for making yourself available, and for, you know, someone who's in the health field, it must have been such a difficult time over the past 2 months, and we really appreciate it. So let me start with one of the more recent questions that came in around screening, since you just covered that. So do you recommend that an organization take the temperature of people entering the facilities, employees, volunteers, or visitors? And if so, what equipment should be used? Our organization experimented with this and found thermal guns and forehead thermometers to be very unreliable.
Yeah, that's been pretty much everybody's experience. I think that if you can, so a couple of things about that. So first of all, and this actually gets to the Patricia Blackwell's question about the fever objective or subjective as well. So people often experience fever differently. Older people don't always mount a fever. People with immune compromise don't always mount a fever. Kids can get very high fevers and be okay. People who are older, not so much. So, and you probably know, in fact, that it is thought that our basal temperature as a species has actually declined somewhat or decreased. So a subjective fever is you feel physically febrile. That is to say, you feel, you know, you may have shaking chills, you may feel really, really cold, even though it's a warm day out. That's oftentimes a more sensitive indicator than somebody's objective temperature. 98.6 is a construct that, you know, people measured temperature a lot in the old days, and then they figured out that that was the average temperature. But any individual normal temperature might be 2 degrees lower than that or 2 degrees higher. Well, maybe not 2 degrees, but, you know, they can bounce around within a degree to a degree and a half. So even that, and that's normal for people. I may mount a fever if my normal temperature is 97 and not 98.6. 99 or 90 or 100 may be a fever. And so I think that the answer to that question is, by and large, measuring people's temperature can be something of a false sense of security, because you don't know what their normal temperature is. And it's oftentimes, not always, but oftentimes more helpful to ask people whether they felt sick, felt feverish, than to measure their temperature, especially with the external guns, which are somewhat iffy. All right.
Great, thank you so much. And someone asked early on, I think you might have mentioned objective fever versus subjective fever. Was that
Right.
something? What is?
Yeah, so, and I was just mentioning that. So a subjective fever is basically you feel hot,
Oh, I see what
feel
you're saying.
feverish, but if you measured objectively, it might, you know, your temperature might be 98.4 or 98.8. But it depends what your normal temperature is. Your baseline temperature might be significantly lower than that.
Gotcha. Okay, thank you very much for clarifying. So this next question coming in from Shan Gordon of Cool Green Schools, and it's about contact tracing. So that was actually something you haven't talked about yet. Do you want to tell us a little bit about what contact tracing is, how it's going to roll out in Maryland? And then Shan had some questions about whether students could do practice contact tracing with their own families. Would that be useful later?
Yeah, sure. So contact tracing is exactly what it sounds like, which is you are trying to trace the contacts of somebody who's had an infection to make sure that they don't infect other people. So the way contact tracing works is, if we are notified of a positive test for somebody who got tested for COVID-19, what the local health department is going to do, or the contractor who's working with us is going to do, is, first of all, we'll interview the person who was infected and try to develop a list of all the people that that person came in contact with. Now, here's where some of those other categories that I mentioned before became important. It's not so important if you're out running in the street and you then become ill. People that you ran next to in the street, even if you don't know them, which is almost certainly to be true, their risk of exposure is pretty low. But if you're spending a day in a cubicle with somebody at work or elsewhere, that risk of exposure is quite high. So our goal is to identify all those people who have risks for exposure, contact them, and then get them to isolate themselves. The way this works is, if you can identify all the people quickly who were in contact with the individual who's sick, and get them to voluntarily isolate themselves, you can stop the transmission or reduce the transmission significantly. That's contact tracing. And I will say that it generally gets done by local health departments. We do have a contractor who will be doing it because it's absolutely critical that it get done, and it needs to be done in a very timely fashion.
And so is it not, it's not quite up and running yet. It's starting to happen. And then people are wondering, can anyone be trained to do it? Can you, and will it be culturally sensitive?
So it is up and running now. We have been contact tracing since the beginning, because our whole goal has been to slow the spread. So the local health departments have been doing contact tracing since the first cases were reported. They've never stopped. But now we're seeing a much larger group of people who need to be contact traced. And that's where we're seeing the need for additional capacity. So if you knew, for example, that you had just been tested positive for COVID-19, and you knew the people around you who um, that you could identify, you spent a lot of time with, those people could be traced by you and urged to self-isolate as well. The goal here is to identify the source of the exposure and the contact, and then get not just the primary contacts if you can, but also the secondary contacts, the contacts of contacts. And that way, if you can do that, the more you can do that, the more you can get both the primary contacts and then other secondary contacts into voluntary isolation, the more you can do to interrupt transmission, because each person who gets infected will infect more than one person.
Thank you. So this one's about masks. So in the past, if you had compromised immunity, you wore a mask to protect yourself. Now we're told to wear a mask to protect others. This is kind of confusing. Can you explain the difference?
Sure. Thanks. That's a good question. So the answer to that is, when you're wearing a mask, um, in most circumstances, what you're trying to do is filter out something in the outside air, dust, small particles, viral particles, something that's in the outside air and that you don't want coming into your lungs. It is certainly true that if you could do that effectively, it would be good to be able to block the openings to your airways in a way that prevented viral particles from getting in there. The problem is that viral particles, when you sneeze or cough or even talk fast or even talk at all, you generate a certain number of small particles that are very light, and they sort of float on water that's in, they sort of float on these little water particles or droplets, some of which are big enough that they fall to the ground, and they usually do so within 6 feet, which is why the 6-foot separation. But others hang there in the air, and they hang there and they're so small that they can actually pass through the mesh of most respirators, especially cloth respirator or cloth masks, I would say. Even N95 masks, which have much, much smaller pore sizes, have some pores, but they screen out a much, much larger percentage of those very, very fine respiratory droplets. When you cough or sneeze, the main job of that mask that you're wearing is actually to stop the big respiratory droplets from leaving your mouth and traveling forward. That's why it protects other people, because those big respiratory droplets do get caught in the mask.
Okay, so thank you very much. So this one is coming in about foster children. So we've been informed to contact the health department if a foster parent or someone in the home tests positive. If their doctor is reporting, will there be duplicate reporting when we report as providers?
So we, we have a number of cases, child care providers, foster providers, et cetera, where their licensing agencies or regulatory agencies have asked for reporting so they can understand the dynamics of what's happening in the community. So when somebody gets tested for COVID-19, the state laboratory, the state health department does get notified of that test result. But in many cases, people don't necessarily even now get a test. And instead, if their doctor says you have COVID-19, stay home, it's very helpful for us to know that by having the notification from either the regulatory agency or the person himself or herself. So it's a way of double checking on the system, but it's also because we don't have enough testing now to know everybody who's infected. So it's really important that we understand sort of what's happening in our various regulated spaces, especially with vulnerable people who may be living in congregate facilities. So that's why we're asking for what may sound like dual reporting, but really is not.
Thank you. And if we can just stay on that for a moment. So when you were on the slide earlier with the Maryland's curve on there, Maryland's data, and maybe if you wouldn't mind putting that slide back up in a moment, because there were some other questions.
Sure.
So I just did some rough math. It looks like 160,000 tests have been done in Maryland. If we have
Hold on a
roughly
second.
130.
Let me go ahead. Let me go ahead and back up. I'm sorry. There we go.
Okay.
There we go.
Yeah, so if we have 130,000 roughly tested negative and 30,000 tested positive, so we've knocked out 160,000 tests, and we understood that the governor managed to procure 500,000 tests from South Korea, and that there are other test availability. So, and that there are still not everyone in the nursing homes have been tested, maybe 20 or 30,000 nursing home residents and staff. So the question is, what is the plan to expand testing, and at what point do we expect to see testing of all congregate living environments like homeless programs, group homes, etc.?
Yeah, no, that's a good question. So laboratory testing is a really complicated subject. It's not simply about having the test. You have to have a laboratory. You have to have a laboratory with the right equipment. You have to have a reliable test. You have to have supplies. You have to have a supply chain. You have to have the logistics to get the test. You have to have PPE, the personal protective equipment to do the test, because there is risk involved in doing this test. And so, I know that people sort of seized on the 500,000 tests and said, why can't we then just test 500,000 people? It turns out to be really, really complicated, because there have been shortages all along the way in things like transport media, the liquid that swabs are transported in, shortages in the swabs themselves, shortages in PPE, and a bunch of other things. We are making significant progress thanks to the governor's efforts, thanks to Dr. Chan, who's leading up Dr. Jinlene Chan, who's leading up our testing task force, and others. We are making progress, and we're doing a lot of testing, especially in nursing homes where our most vulnerable residents are living. But we recognize there are a lot of other vulnerable populations too. We're getting out now to more congregate facilities. Dr. Howard Haft, who leads our primary care group, is also working with a group that's been going out to homeless shelters, shelters for people who are experiencing homelessness, to do testing there. We're talking about testing in the prisons. So there's a lot of testing activity going on. But all of that being said, we're talking about, at this point, we've tested a little bit over 2% of the Maryland population. And some of those tests are of necessity repeat tests, but most of them are not. That means 97% of the population has not yet been tested. I can't tell you exactly when that time will come. But I can tell you that it is absolutely the top priority of the administration and the health department to make sure that we get testing capacity up, because at the end of the day, we will not know where we are if we don't have the capacity to test widely.
Thank you very much. We do understand the complexities. I think it would be helpful to see some sort of set of goals and roadmap, even if we don't know exactly when each of those pieces would come online, to know that the state is prioritizing all congregate care facilities and vulnerable populations would be super helpful. So along those same lines, the governor has put out, the roadmap to recovery, the Maryland Strong,
Yep.
And there are 3 phases: the low risk, medium risk, and high risk. Can you tell a little bit about how you foresee that playing out, related to people are asking questions about are summer camps going to be possible? If they're planning a gathering for seniors in August, should they be planning that or not planning that? So what should people expect to see from the testing and tracing and policy side of each of those phases as they unfold?
Well, you remember that magic 8 ball, the one where you shake it and
Is
it
you ask
says
me again later?
reply hazy, try again later. Yeah, so there are two things. The first is I can't second guess and I can't advance guess the governor. The governor is making these decisions with a lot of input from a lot of people. And it would be irresponsible of me to try to speculate about what the governor might decide and when. So the simple answer to these is I'm sort of in the same position as all of you, which is I look at the data regularly. I think about where we would like to be as a state in terms of our infections, hospitalizations, ventilated patients, patients in intensive care, and deaths. And I'd like to see all those numbers going down. But I do not know when the governor is going to decide that the conditions are right to take the next steps. I don't know what those next steps are going to be. I don't know how long he wants to let to wait and see sort of how things roll out before making decisions on another set of changes. Remember that it takes about 2 to 3 weeks for a change to work its way through the current system. That is to say, if you make a change, the change that you make today does not result in a change in infection rate tomorrow. It takes a while for that to sort of work its way through. So you don't expect to see changes for 2 weeks. You don't expect to see a change reflected in the actual infection rate or number of hospitalizations or anything like that for 2 weeks or so before. And so I guess what I'm saying is that we're watching, we're looking at the data closely. There are a lot of experts advising the governor, but I really do not know. I really don't. What the governor is going to recommend, what the governor is going to decide, when the governor is going to decide it, and what that suite or the next suite of changes might be. I really don't know.
Thank you. And I am a part of the governor's nonprofit work group, and we are talking about summer camp on that. Several of the summer camp providers said that they would perhaps be serving fewer students and only outdoors and only certain age groups, but no one's totally clear on what their summer plan is going to be. We have 2 people in our group, either one person, and so sorry to the person who is currently living with COVID, and she's on day 52 of symptoms, and she's part of a Facebook group called Long Haul COVID Fighters. And there's another person who said that she's got an employee, or more than one employee, two employees who have tested positive, then negative, but they've continued to have a fever for going on 60 days. So can you talk about these long-term COVID cases? And
yeah. So I mean, there's a lot we don't know about this virus. So let me just give you some of the things that we don't yet know. We don't yet know, for example, we do know that if you become infected and your symptoms resolve, you can continue to shed small amounts of virus even after that and test positive. So we know there are cases where people may continue to have, will still test positive up to a month after their symptoms started, in spite of the fact that they're feeling physically better. We do not know at this point whether and to what extent those people might potentially still be infectious. We don't know with asymptomatic people how many of them are going to go on to develop symptoms and how many of them are just going to remain asymptomatic. We don't know whether being asymptomatic and COVID positive means that you are more or less the same infectious to other people as somebody who has symptoms. We know that people are capable of having long-term symptoms. And that includes not just fevers, but also we've seen late stage kidney problems and other kinds of problems with COVID patients who, where, the symptoms they've continued to have problems well after that sort of short 2-week period or 10-day period where you think they're mainly that most people will resolve. So there's a ton of stuff we really don't know about this virus yet. And it's something that is going to continue to be a challenge for us, is how to manage with the uncertainty that we have, both in terms of testing and in terms of the symptoms that people are experiencing.
Thank you. And we are up against 4:30. Do you have a few more minutes for a couple more questions, or do you need to wrap?
I could probably take a couple more questions, although it suddenly strikes me that I may actually have another meeting, which is sort of the way my life is going.
I imagine it's wall to wall for high demand.
It's a little chaotic, yes. And the answer to that is, the magic answer is, oh yeah, no, I do actually, I am supposed to be in 2 other meetings now.
2 other meetings, okay.
Yeah, so, and I apologize, but.
That's all right. As we wrap up, a number of people asked about mental health. Is there something you would like to say about the mental health related to the trauma being caused by the?
Yeah, that's I work very closely with Alia Jones and Stephanie Slowly from the Behavioral Health Administration. They have done a huge amount of really, really good outreach that many of you probably know.
So maybe we can do a webinar with them next.
I would definitely recommend that you talk with them, because this is, as we haven't done this as a species since 1918, and most people don't remember that well. And so it's really, it is really true. It's really tough for people. And like, I suspect that many of you, like many of us, recognize that this is a long-term thing that is going to happen. Mental health challenges and exhaustion and, corona fatigue and a bunch of other things are likely to become syndromes of one kind or another. And it really, people have to have something to look forward to. And also for people who have mental health issues, this is obviously a very challenging time. So I would definitely recommend talking with the 2 of them.
Okay, thank you so much. And would you mind if we sent you some questions in writing?
I would not mind at all. I will tell you that my colleagues here will be happy to work on those questions with me. And they, as opposed to me, are actually quite reliable. So Eamon Flynn is on, and I know that between him and our other staff members, we'd be happy to get back to you on that.
Terrific. Thank you so much, Eamon Flynn. Thank you so much, Dr. Clifford Mitchell with the Maryland Department of Health. We so appreciate you joining us today. This is Heather Iliff at Maryland Nonprofits, and thank you all for joining. Have a good rest of your day and stay safe.
Thanks. You all stay safe and be well. Bye-bye.
Bye-bye.